Welcome to Introduction to Clinical Psychology, Psychology 3339. I'm Dr. Edward Sheridan, and we're going to be studying a really fascinating field. And I think you're going to find that clinical psychology really it's interesting, it's fun, it's a very broad field. And, you know, in one course, we're only going to be able to kind of touch on a number of things that you would study in depth, really, in other courses. In fact, many of the sections that we will discuss in our class actually become whole courses. We will talk about personality development, and there's a whole course on theories of personality. We'll be talking about abnormal psychology or psychopathology. There's a couple of courses on that. We'll be talking about psychotherapy. There's a course in that. We'll be talking about psychological testing. There are numerous courses on psychological testing. And we'll be talking about professional issues in psychology, of which there are many. So you'll kind of get a sense from this course about what might be other courses in psychology that you would be interested in taking. I want you to feel very free to ask questions, to offer your opinions, to raise any issues you want to raise, because that actually helps me to be sure that we're moving along in a way that you're following what I'm presenting. And also, a lot of this material lends itself to questions and to and you just may want to offer your own opinions even. Also, you may want to take a position against whatever the position is that I'm taking because your own thoughts tell you this doesn't sound right. And that's fine. I absolutely want you to do that. Now, necessarily, when you take a course in a professional field like clinical psychology, depending on who teaches it, you'll get different biases. So I should probably tell you my biases by telling you at least what my background is like. Early in my career, first of all, I should tell you my PhD is in clinical psychology. So I did get my doctorate in this particular field. And you'll see on the syllabus, at least I think it's on the syllabus, yes, you'll see that after my name it says PhD. And then, Scott, this is not on. We always run into a mechanical error here or there.
Just tap on it.
Tap on it? Okay. Maybe I'm not tapping hard enough. Well, we'll continue on while occasionally there's a mechanical error. Anyway, it says ABPP. Now, what that means is that a person has a diplomate in psychology. In my case, it's in clinical health psychology. And that's a practitioner credential. What that means is that after you had your PhD for at least 3 years, you decided to undergo an examination that's given by the American Board of Professional Psychology, in which you take exams and you present cases and you're examined on ethical dilemmas, etc. And if you pass the exam, then you're considered a diplomate in the field, which is a level considered beyond that of having a PhD. Now, in my career, I spent 17 years at Northwestern University Medical School in Chicago. The first 8 of those years, I was the chief of psychiatry outpatient services. And I started off running a modest-sized clinic in a medical school. But there was a lot of money available. This goes back in the 1970s, long before most of you were around. But in those days, money was really available. And I was able to build this clinic into the largest mental health system in the Midwest. So I'm very familiar with running a lot of clinics, and I will tell you in some of the examples I'm going to give you will be stories from what actually happened in these clinics. After 8 years, I became professor and chairman in psychology in that medical school. And during all of that time, I also was in private practice. And so I was seeing private patients doing psychotherapy, individual psychotherapy, group psychotherapy, and marital counseling. And we will discuss all of those kinds of treatments as we go on with our class. Later I got into administration, so I became a dean, and then I became a provost. Became a provost at the University of Missouri in Columbia. Then I came here where I was the senior vice president and provost of this university, also the senior vice chancellor of this university systems. And so I went from a very active clinical world into an academic world. And you'll see as we talk about careers for psychologists that people do that people get involved in various areas and do different things. What you will find also is that many of the issues that come up are issues that you can take a stand on. That is, it's not like this is the right way. So the reason I'm telling you about my background is that you'll know I've come from a certain background, especially one that's very heavily involved in big medical centers. And so I've had to look at the problems that arise in big medical centers, but I've also had to look at the problems that come from running a private practice by myself. We'll mention later on, by the way, that that's almost a dead field now. Not many people are going to go into individual private practice because of the nature of how healthcare has changed. Well, let me start off, of course, by asking you, what do you think clinical psychology is? That is, when you decided to sign up for this course, what were you saying to yourself? What am I going to learn? What am I hoping to learn? What do I think this field is about? Just doesn't matter. Just give me some idea. Sure.
Okay, my major is psychology, and what I plan to learn by taking a clinical psychology course is possibly some information on forensic psychology, because I'm thinking about going to criminal psychology and perhaps going to graduate school.
Okay, and that's interesting. We're going to devote a fair amount of time to forensic psychology, which is a newer area, but it is a fascinating area. And we'll talk about some of the classic cases in forensic psychology and in the whole forensic world. What else? Well, surely you had a reason for taking this course rather than the time frame that it was in.
Make sure you use the
Okay. Oh, I see. Okay. Oh, I see. When you ask a question, you just means pull the mic towards you. Okay. Any other?
Well, I would like to say that the reason why I'm taking this course, number one, is it's my minor. And
Okay.
it's necessary that I take this course. But also, I want to work with abused children and juveniles. So I think that it would teach me, some things about the interaction as far as drugs and anything else, how people respond, in the clinic scenes, and, how they treat and how they work and, get these kids back on the right road. So I think it would help me in that sense.
Okay, fine. So a couple of you have real practical aims, and you're thinking about a career. Well, that's great. Now, what you'll find in this field, in clinical psychology, is that, it only has a history. Your book will tell you it's about 100 years. And, typical of fields, they go back and they kind of trace, like, where were the first signs that this field was developing. And in clinical psychology, they kind of go back 100 years. But the truth is, clinical psychology as it is today actually has a history of about 60 years. And you'll find, and we'll talk about this a fair amount, the field actually started the way it is today during the Second World War. And I'll give you some examples about the Second World War and about how psychology, in some way almost accidentally, grew into this huge field that it is now and became a field very oriented to working with troubled people as well as working with many other kinds of people. But clinical psychology has had its major focus in working with troubled people. Now, during that 50-year period, also, the American Psychological Association, which is the largest organization of psychologists in the world, has grown to 155,000 members. And when you have 155,000 members, you obviously have lots of interests. So what's happened is psychology has developed a lot of divisions. That is, the American Psychological Association has a lot of divisions. And Scott, if you can show the first, thank you, Wayne. Here are some of the divisions you'll see, and the numbers here happen to correspond to the way in which we identify divisions. We often refer to them in psychology as like Division 12, and Division 12 means a division of clinical psychology. And you'll see here we have consulting psychology and school psychology and counseling psychology and rehabilitation psychology. And actually it goes on, and you'll notice even when you get to, well, I didn't put in forensic psychology, but actually forensic psychology is in this group. But all of these divisions I'm telling you about, if you notice, they all involve a certain kind of expertise: psychoanalysis, clinical neuropsychology, family psychology, addictions. Even the distinction, you'll notice there's clinical and child and adolescent psychology, and there's pediatric psychology. The first group refers to those who are especially interested in working with children who we have identified usually as having psychological problems. Clinical child psychology has focused heavily on those youngsters who have diagnosable psychological disorders, whereas pediatric psychology refers to a broader field, and it refers to not only children who may have some psychological disorders, but it also refers to children who may have developmental disorders, to children who have physical diseases or physical problems that have caused them to have certain psychological problems. And so it is somewhat of a bigger field, and it's been differentiated even so that we have some psychologists who want to identify with one division, other psychologists who want to identify with a different division. Now, when you're studying clinical psychology, you're actually studying a field. Of course, it's a subfield of the whole big world of psychology. So as you can see, clinical psychology is large, but it's still only one field of many in psychology. And then when you see how, on the slides we just showed, how this field subdivides itself more and more as we gain knowledge. Fields are becoming smaller and smaller. That is, people are having to make decisions in their career. Do you want to work with children? Do you want to work with adolescents? Do you want to work with adults? Do you want to work with older people? Do you want to work with people who perhaps have physical challenges in some way? Do you want to work with people who have had brain injuries? But there's so much to learn that at some point in one's career, most people make a decision: I am going to focus on some group. And that group becomes the people that you work with. Also, what you would want to know about clinical psychology, there are two other fields: counseling psychology and school psychology. Now, anybody who's in these fields will tell you, well, clinical psychology is one thing. Counseling psychology, they will define a little differently. School psychology, they'll define a little differently. The truth is, and this is especially true in the distinction between clinical psychology and counseling psychology, once people get their degrees, they almost do the same things. I mean, they're almost, you can't distinguish people who have PhDs in counseling psychology, people who have PhDs in clinical psychology. The only difference is how they got educated. And often, I mean, many of the courses are exactly the same. One of the reasons why counseling psychology developed, though, and why it remains independent, is often the doctoral program in counseling psychology is offered in a college of education, whereas most of the time the PhD program in clinical psychology is offered in the College of Arts and Sciences, and if not, then it's offered in a medical school or in some other setting. Now, as you know, clinical psychologists are providers of mental health services, and there are others who do this. There are social workers, there are psychiatrists, there are nurses, there are family therapists. There are lots of people who provide these kind of services. But there are some distinguishing characteristics about what clinical psychologists do. First, clinical psychology really has its own basic science. That is, psychologists really are the ones who have studied the development of personality theory, and also very much have studied abnormal behavior, namely psychopathology or abnormal psychology. Those two areas really form the basis, that is the basic science for the study of psychology. Also, psychologists are the one group that, of necessity, it's demanded of their training, they are trained in research. When you get a doctorate in clinical psychology, it is not only assumed that you're capable of conducting various kinds of assessments and various kinds of psychotherapy, but it's also assumed you know how to investigate this, that you could actually do studies that would further the field. And another distinguishing characteristic in psychology is that we've developed so many tests. And these tests help us both with research and they help us with clinical work. So the very same tests, for instance, that we might use to determine what is someone's IQ, what is someone's level of depression, how obsessive is this person, those same tests often are the instruments that are used when we do studies on people. And that really does distinguish psychology from other disciplines. Now, in nursing, for example, that is not a research-based discipline unless we're talking about nurses who get PhDs. Then they do have research training. Same is true in social work. Social work, vast majority of social workers are at the master's level. Now, those who get doctorates, of course, do have research training. And of course, amongst physicians, training of physicians does not involve scientific training. I mean, physicians are not scientists. It doesn't mean that many of them don't become scientists, because you'll find that some physicians, once they finish their training, will go to a place like the National Institutes of Health, where they get specialized training in research. And those people are excellent researchers. And there are some physicians who also get PhDs. But we're just talking about the field in general. If you just did your medical training, or you just got your master's degree in another field, you won't have the kind of scientific training that we have in psychology. Now, there are some clinical psychologists who actually spend their whole life just doing research. That's a very small number. The vast majority of people who get degrees in clinical psychology really do spend their careers doing assessment and psychotherapy. And psychotherapy, in the broadest sense, is probably what occupies by far the largest number of psychologists, and it occupies the most time of psychologists who do other things. This is a real controversy in the field, by the way, because since the degrees are offered in universities, often the people who are teaching are people who are most interested in research. And they want students to come out of their graduate programs often to become researchers. The reality is, most of the people who come into this field don't have that as their major interest. Most have as their interest, I would like to learn to do psychotherapy, I would like to learn to do psychological testing, I would like to learn to work with people, like in your case, to work with children who have very complex problems, or to like to work in the forensic system, which is a very complicated world. But that's what most people want to do. So we do have a problem in our field to some extent, in that those who teach in the field often are interested in the research area, and those who are being taught are interested in other areas. And you'll see when we talk about some national conferences how this conflict gets played out over and over again. Now, I do want to say, though, that there is still great pride in psychology in the fact that, and I mean amongst practitioners, over the fact that they are trained to do research. Even though most of them will not do research, people really appreciate the idea that they've been taught to think as scientists. Because when you think as a scientist, one of the things that happens is you're constantly questioning what you're doing. And you're constantly trying to think of better ways to do things. And you're trying to examine, is this really the best way that I could operate in helping someone to get better? And And you'll find as we talk about national conferences that this theme has run through psychology for a very long time, and people really do like it. Now, in terms of everybody has a definition. Here's the definition of clinical psychology, the official one that's used, and it's about 12 years old now. And you'll see it says that the field of clinical psychology involves research, teaching, and services relevant to the applications of principles, methods, and procedures for understanding, predicting, and alleviating intellectual, emotional, biological, psychological, social, and behavioral maladjustment, disability, and discomfort applied to a wide range of clinical populations. You can tell that this was made up by a committee and that everybody got their say. And so not much has been left out of this definition. And the purpose of it, though, and why it's important, is that it does try to say that the problems people have are complicated. That, you know, we're looking not only at intellectual problems, which is psychology started off very much looking at intellectual functioning, but emotional functioning. That biological functioning is very relevant, especially when we get into areas like health psychology and neuropsychology. Obviously, we deal with psychological issues, but there are social reasons for why some people behave the way they do. And if you don't take social and cultural reasons into account, then you may make serious mistakes in trying to understand a person. Now, what we're going to do is we're going to try to look at what are the areas in which psychology gets involved. And I'm going to show you a few areas here, 6 areas specifically, that your textbook tells you are kind of the broad areas that they want to discuss. By the way, the definition that I just gave you is in your textbook, so don't worry about it. Now, the 6 areas are assessment, treatment, research, teaching, consultation, and administration. And as I've said before, you know, while some psychologists devote all of their time to one or more of these or to several of these, by far the most time is spent in treatment. Now let's talk a bit about assessment. How do you think a psychologist assess people? I mean, if you were going to send someone to a psychologist, if you're going to go to a psychologist yourself, how do you think they go about assessing people? Someone comes in with a problem. What do you think they do?
Number one, they have to talk to them.
Aha. Yes. Okay, right. Now, the first thing you do is you interview someone. You have to find out about what is their problem. Okay, what else do they do? Supposing you interview someone and you still can't figure out what the problem is. What might a psychologist's next step be? Aha, yes, correct. Yeah, if you talk to the person and you still say, you know, I really don't know what is this person's problem is, then you have the opportunity to test someone. Because often people will tell you through the ways they behave in tests and the answers they give in tests, they tell you a lot about themselves. Sometimes things that they don't know how to tell you when you're interviewing them. And so that becomes very important. Now, there's a third thing that psychologists do also. When a person first comes, as we said, you interview the person. If you can't figure out the problem, then you might test them. But also, you make observations about people. It's striking. Someone comes in, and let's say the person walks into your office, and the person is very nervous and fidgety. They're having a hard time sitting down. You can visibly see this person is anxious. Now, if you were the psychologist, what might you start thinking about this person? Someone's real fidgety, nervous. You can tell they're nervous. Let me say, what would you think about them interpersonally? Think they're smooth interpersonally? Think they have difficulties interpersonally?
Yes.
Okay. Yeah, probably the first thing you notice is this person, and you use what's going on between you and the client that's come in to get a sense of, what is their problem. So what you see is, here's somebody who is very anxious. They're not at all comfortable, even though they're in what might be considered a safe environment. For many people, it is not a safe environment. But their first way of relating is to show a lot of anxiety, a lot of uneasiness. Now, supposing somebody came into your office and the first thing they said is, boy, I don't like the color of these walls. And boy, you got a couple of terribly ugly pictures up there. I don't know why you put those pictures up. And I don't like the seat. What would you?
Critical spirit.
Critical, haha, yes. Okay, and so what would you think might be one of this person's problems?
Maybe they like to control their situation, and they walk into an environment, I don't like what I see. If it were me in charge, I would change something. So let me let you know what I like, what I want done.
Okay, very good. This may be a very controlling person. You'd want to be aware of that as interviewing the person. What else might you pick up on about with this person? What affect have you noticed?
Have a very negative attitude, very negative mindset.
Yes. In fact, you might begin to think, this is kind of a hostile person. I mean, imagine somebody comes into your home and they say to you, gee, I don't like this apartment. Well, and it's the first time they've been there. So you start realizing, and so this, begins to suggest, if the first time the person shows up in an environment, and they become critical, what do you think their chances are that they have good interpersonal relationships?
Not very well.
Yeah, probably this person has got some real difficulties in relating to people. That this is not the kind of person where you say, boy, I'd really like to get to know him or her. Your first thought is, how did I get stuck with this person? So you make observations because it helps you to understand when this person later on, and you can bet this is going to come up in therapy, the person is going to say, I just have a terrible time, getting close to anyone. Well, you can see why, because the first time the person is with someone, they send off all kinds of signals that they're not a very desirable person. So probably people are not going to seek relationships with this person. And also there are nonverbal observations too that one makes. People communicate in a lot of ways in the clinical setting. I was thinking of a case one time. I saw a woman. I was seeing her for the first time, and went out into the waiting room, and she got up. She's a very, very nice person, and she holds out a hand. We shake hands. The first thing I noticed was that this woman's hand was really quite big for a woman, and the way just she presented herself, I said to myself, that this person is transsexual. And now, the woman had not told me that beforehand. And actually, she did not tell me she was a transsexual till the third session. And she came in, and she was married, and came in to talk about a number of problems. But only in the third session did she actually start saying, I actually was born a man. I had transsexual surgery several years ago and made this change. But somehow, you learn to pick up those things, even though someone has not told you. And that becomes part of the whole clinical enterprise of trying to understand people. And of course, that only happens after you've seen lots and lots of people, so you begin to recognize that there's something about this person that is different than other people. But it's very important clinically that one develops those skills. Because in this particular case, once I made that observation, I chose not to ask this person about her sexual life in the first couple of sessions, thinking, when she's ready, she'll tell me. And as a result, she got very comfortable. And so when it came time, she said, there's something I should tell you. And then she tells me. I think if I had probed for that in the first session, it might have created too much anxiety and I might have lost her. So there's an art, really, to getting information. And sometimes, even though you suspect that someone may have a major problem, you do not seek to get that information right away, because in interviewing, it's more important to try to make people comfortable, first of all, to enable them to feel safe with you, and then you can talk about these very serious things. Okay, now the next activity we mentioned in our list of 6 is treatment. And we're going to spend a fair amount of time, by the way, in our class talking about psychological treatment and the various kinds of ways treatment is conducted. It's certainly what has drawn people to the field. I mean, people who get into clinical psychology really like working with emotionally troubled persons. But the field has gotten broad enough that there are now different subgroups. There are people that we would think of as emotionally troubled, meaning like they have behavior disorders, or they may have very serious psychoses, they may be schizophrenic, and people want to work with them. But there are also clinical psychologists who work with like the developmentally challenged persons, people who have low IQs. And that's it's a very difficult field and a very important field, especially when you get people who are adults, but they have low IQs, and therefore they can't work often in the kinds of jobs that you expect most adults to work in. And we have programs for developmentally challenged or intellectually challenged adults so that they can do meaningful work. And it takes a great deal of sensitivity to figure out, what kind of jobs can someone do, and then to employ them, and then pay them something for that. And also, often within that culture, you have treatment for them to learn social skills. A friend of mine ran a clinic like this, and I remember she was telling me that one of the things she wanted these people to learn, these are all people like in their 20s, all with IQs below 75. And so she decides that they have enough skills they can go out and eat, which is something they haven't done before. So she takes them to Howard Johnson's. And so she calls Howard Johnson's ahead of time to tell them, I'm bringing 20 people who are a little bit different than the people you usually get. And teaches them skills, first of all, of how to pay the bus driver, because they decided they would go by bus. So they get on and they get there, they put their money in, and then they get there and they learn how to read a menu, and they learn how to order. And all of a sudden, I mean, they can now do things that they could not previously have done. In other words, their world is expanding. And people had not encouraged a lot of these people, because the families became very overprotective of them when they first found out that they were developmentally behind, which is unfortunate. Now, also what psychologists have discovered in getting involved like this is that with some people, what really occurs is that they are very emotionally troubled early in their life, but not enough attention was paid to them, so they get seen as being retarded. They get seen as being intellectually challenged. When they become adults, they've been treated so much like they are intellectually challenged that they behave that way. And I remember this person telling me, she was running group therapy for these people. And he comes in first day and has people sit around in a little group, and she's going to ask them some questions. And one person in the group says, aren't you going to tape record this? And she says, why would you say that? He said, well, I've seen on television, when you do group therapy, you tape record it. Well, right away, what she realized was, this person is not retarded. This is very bright observation to make. This is a very astute observation to make. But as she looked into his past, she found out that that actually he probably was schizophrenic when he was 6 or 7. And they began treating him, because they didn't want to deal with the fact that he was emotionally disturbed, so they began treating him as if he was intellectually deficient. Well, he got treated that way for so long, he got labeled as if he was intellectually deficient, and now he's an adult, and he's still being treated as if he's intellectually deficient. He's not. Actually, a pretty insightful guy. But those are the kind of breakthroughs that people have. Now, we also have people who are brain injured. And when we talk about neuropsychology, psychologists have been working with the brain injured for some time, with people post-stroke, post-brain surgery, pre-brain surgery also. And neuropsychology has really done a lot to help in this field. I mean, they've developed programs for people who have strokes or people who come out of brain surgery. And if you look at the way medicine has dealt with this, and it makes sense the way medicine would deal with it, medicine tends to deal with the acute problem. That is, somebody has a stroke, so you try to stabilize them, somebody has a tumor, you have to take the tumor out. The neurosurgeon's job is to get that tumor out. However, after surgery, many people don't function very well. And the belief for a long time was, especially before neuropsychology became so common as it is today, that somebody wasn't functioning a couple of weeks after brain surgery. Well, they probably lost a lot of function. The tumor had affected them in such a way that they weren't going to get much recovery. Well, neuropsychologists began looking at this phenomena, and what they discovered is actually you can't tell post-surgically how much recovery someone will get until about a year after the surgery, and that you can help enhance how much recovery there will be by developing programs for people where they learn to work on things like their memory, they learn to work on relating to other people, they learn to work on those things that seemingly were damaged by, and not seemingly, they were damaged by the surgery, but it doesn't mean it's permanent. And psychologists have done a lot of work that's really very exciting in that area. Now also, psychologists work with people who have very specific behavioral disorders. Many of you are probably familiar with the fact that psychology came up with the first programs in smoking cessation. In fact, Dr. Richard Evans, who is right here in the psychology department, was the first person in the country to really develop smoking cessation programs. And as you know, I mean, that's the most effective public health intervention probably we've had in the country. In fact, there are probably two amazing public health interventions. One is how many people have stopped smoking. I mean, it's really dramatic in the country. By the way, an interesting fact is most dramatic amongst physicians. When I was first working in a hospital, I mean, just about everybody smoked. I mean, I remember we used to have a conference room, and there were about 12 of us who used to meet. We were running various clinical services, and I think I was one of two people who didn't smoke. And it was a room that didn't have any windows. I mean, and the smoke was really thick. And that went on for a few years. And then one day, I was chairing this group, and a young psychiatrist said to me, he says, Ed, I'm the youngest person in this room, but there is enough research out to say we should not be smoking in this room, and we shouldn't be inhaling each other's smoke. And this was just at the time when there was really, that research was really getting attention. And I said, well, you're right. And starting next meeting, there will be no smoking. And everybody in the room knew it. I mean, it took the youngest person to say it, but the truth was everybody knew there should not be any smoking. And about a year later, of course, the hospital declared it, as all hospitals did, declared themselves smoke-free. And physicians learning about the problems of smoking have had a dramatic, I mean, physicians went down to, maybe 1% of physicians smoked after all this research came out. That's a tremendous change. Now, the other intervention, in terms of just, understanding like how prevention can work, because we're going to talk about prevention, but the other seatbelts. I mean, if you look at the data about fatal accidents before seatbelts were mandatory, and then after seatbelts were mandatory, and if you look at accidents today, and you look at those people who are hurt or even killed in accidents, and then you see how many of them were not wearing their seatbelt, you see that it's dramatic. That these kinds of preventive interventions, some psychologists get very interested in, have tremendous implications. Then, now psychologists also, this is something people aren't as aware of, work with people who have physical disorders. I mean, people who have headaches, people who have ulcers, burn victims. There are any number of treatments that psychologists use to help people with headaches. And often the psychologist is called in after a neurologist or another expert has worked with the person and found that what they're doing is not working, that his medication is not helping, it wouldn't make sense to do surgery. Psychologists come in and they do any number of things, including biofeedback, relaxation training, and various interventions that have been found to be very effective in either reducing the pain from headaches or actually eliminating the pain. Of Of course, psychologists work with people who have interpersonal disorders. Most common, obviously, are marital therapy. Psychologists do lots of work with couples, and family therapy, which we'll discuss later. Now, psychologists also work in organizations where they deal with communication problems, or they deal with stress or motivational issues. Now, there is a field in psychology now, industrial organizational psychology, where the people who go into that field become real experts in this kind of work. And, but because that's a relatively new field, and because clinical psychologists often got opportunities to do consultations, they also got into this work. Now, clinical psychologists don't have the sophistication that industrial organizational psychologists have in a lot of tests that are used in that field and in a certain number of areas, stress management, et cetera. But they still do get involved in consulting to organizations. Now, in conducting treatment, most treatment is conducted one-on-one. You know, psychologist, client, or patient. That's the usual setup. But they're not necessarily that way. If you're doing marital counseling, obviously you're seeing two people. If you're doing family therapy, you may be seeing a whole group of people. So that we have found that some interventions simply don't work well. That is, one-to-one won't solve the problem. You've got to involve other people. Also, psychologists work with people in groups, and there are various kinds of groups. One can be a group of anonymous individuals who have emotional problems. And by anonymous, I mean that the people who come together didn't know each other before the group started. They all agreed to be in group therapy. They may want to work on a fairly common problem like their interpersonal skills, but they also may want to be working on things like they're depressed, or they've had a couple of failed marriages, or whatever. But group therapy, and we'll discuss the dynamics of group therapy later, but group therapy is a very effective intervention. Also, psychologists work in groups with people who have a very precise problem in a way, like gambling. And it's been found often that you can be more effective if you get a group of people who are addicted to gambling and you work with them in a group than if you work with them individually. We also found this to be true in drug dependence. You know, the early days, especially when we were trying to figure out how you work with drug-dependent people, and we sure didn't know much about it. But one of the things we learned early was the power of the group, because often people who are addicted do a lot of lying. A person comes in and says to you, "I will never take a drug again." And you know, you think to yourself, I've heard this before. And you know, this is probably untrue. But it's very different when they come into a group and they say, "I'm not going to do that again." And then there's a burst of profanity from other group members telling the person that they don't believe this at all. And so let's get serious here. And let's just see, what are you going to do to stop being on these drugs? And it became very clear that you can get much more done in a group, that it's a more potent kind of treatment, it's a more effective kind of treatment for a very specific kind of disorder. Now, the other kind of group that psychologists work with are people who may be in training for high-risk activities, like, say, the Navy SEALs are going to go off on a mission. There are dynamics that you can teach people, like, first of all, how to work as a team. Another is, you know, how to pay attention to a leader and to follow orders, because often what they do is so precise. And to teach them to be aware of their own feelings. That is, you are going to be anxious. You may even be traumatized by things. You may see some terrible acts, people being killed. And to prepare people for all kinds of things that may happen. And you do it in a group so that they begin to understand that the guy who's next to me has had the same kind of training as I have. And we all know that this is a very scary thing to do. And that there's high risk here, but we can lower the risk if we follow certain procedures. So, as you can see, I mean, there are just lots of different ways in which one's training may take one into working in different ways. Also, Well, I was saying, usually you have one therapist and people. It's not necessarily the case that in groups. Sometimes in groups you have two therapists. In marital therapy, sometimes you have a male and female working with a male and female. If that's the dyad. Today, of course, you may have gay couples coming in, and you may have various other kinds of dyads coming in. People are not necessarily married, but they are a couple, and they want to work on their relationship, and you may have more than one person. Most of the time, though, there's only one therapist. And historically, the time limits for these sessions, individual sessions, historically, there's the famous 50-minute hour that you hear about. And individual sessions usually are about 45 to 50 minutes. Group sessions usually run anywhere from 1 to 2 hours, and probably more commonly like 90 minutes to 2 hours are the time frames for them. However, back in the 1970s, they were kind of testing the limits of group intervention, like how long, is the right amount of time. And they began extending groups out, even as much as running a group continuously for 24 hours. And what the theory at that time was that some people in 2 hours keep all their defenses up. So they're in a group for 2 hours. They never really become themselves. They never really disclose much about what they're feeling or thinking or what's hurting inside. But after 4 or 5 hours, or even 8 hours, they get so tired, their defenses kind of lapse. And then they really begin talking about themselves. And that if you really want to get to this person, you need to have these long sessions. Now, this went on, and actually, we had sessions as long as a day, and sometimes people did them for like 8 hours and various kinds. But the truth was, there wasn't enough research to support that there are enough people that you really want to develop these marathon sessions. Also, people had a hard time putting that much time aside. Therapists weren't that eager, except a few unusual people to put in that kind of time. So that movement has never caught on. And today we're back more into most groups run for smaller periods of time or shorter periods of time. Now also, interventions can run anywhere from like one session with a person to many sessions with a person, years with someone, and that you may be over that time, the problem someone presents may change. Someone may come in, for instance, very depressed. The immediate issue may even be whether the person is going to commit suicide. And as you work with the person, and the person becomes less depressed, and there's really not an issue of suicide, but the person then begins talking about their interpersonal difficulties. They may be talking about the fact that they've always been an underachiever at work. They're afraid to take risks. They actually know they're much brighter than they come across because they're just not comfortable really showing all their skills. And any number of things can change over time. And so while one is in therapy continuously, let's say for a long period, it's not necessarily the case that actually they're in therapy for the same reason. You'd have to talk about what part of the therapy are we talking about? Because in the beginning, the issue may have been very focused, like let's keep this person from ending his life. Later on, it may be let's help this person to really develop a meaningful marriage or to function very well at work. Now, all the things that I've been mentioning up to now are focused heavily on intervention. However, there is an area of prevention that psychologists get involved in. They get involved in it less than other things, not because it's not really challenging, but because, our society is reticent to fund prevention. It's fascinating. We know there are things like it's much better to keep people from smoking than to try and treat smokers. But we are very hesitant to allow payment for such things. So prevention doesn't get the attention that it could get. However, there are some things where you just have to work with prevention. For example, when the AIDS epidemic first hit, it was in the early 1980s, we discovered this HIV virus. Now, those were very tumultuous times. And I remember the AIDS center that we had at Northwestern Basically, what the dean of the medical school decided was that we need an infectious disease physician, because obviously HIV virus is an infectious agent. We need a psychologist because most of the people who were being diagnosed with HIV in those days were people who were in the closet. That is, they were mostly gay males, and they had not yet told people, except very select group, that they were gay. And all of a sudden, they were terrified over the fact that being HIV positive would mean they would be outed, and many people became suicidal. So it became important, if you are going to work and you're going to run an AIDS clinic, that you be sensitive to the people that you're going to diagnose as being HIV positive are going to have tremendous emotional reaction to it. And of course, by the way, you know, back in those days, everybody died. So, I mean, not only were you going to be outed as a gay person, but on top of that, you're being given a death sentence, is how people felt. And in those days, we had only one drug, so we didn't have a lot to work with. Also, there were a lot of problems with the law, and the dean thought we needed a lawyer because, first of all, insurance companies just arbitrarily decided we're not going to pay for people who are HIV positive. So when people went for treatment, insurance companies sometimes denied claims. A bizarre thing to do. I mean, it's like, you know, you get infected with one agent, you're infected with another, but if you're infected with HIV, we won't pay. If you're infected with something else, we will pay. And also schools. They found kids, you know, little kid who became HIV positive because of a blood transfusion. They didn't want the kid in school. And parents began getting all excited. I want my kid in school with kids HIV positive. So it became necessary to sue. So they started the AIDS Center by getting a person, the chief of infectious diseases, and a psychologist who was a lawyer. And they began to look at what do they need to do. Well, there wasn't much they could do. So they decided we'll have to start prevention programs. And so they developed a curriculum all the way from kindergarten to grade 12 to teach kids about what AIDS is about. And they actually found ways to educate kids even at the kindergarten level and first grade level, and then to move up so that they would know what they needed to know. Now, we're going to stop now and take a break, and we'll start back again in 5 minutes.